do want to just briefly cover some bone grafting concepts, because how are you going to place implants if we're not good at socket preservation, right? That's the biggest thing. So I want to briefly go over that. We made this like 600-page curriculum like a couple years ago, and it's like a cheat sheet. It's got like a bunch of secrets in here for you guys. Does everyone do socket preservation in their practices right now? Yeah. Who is in the camp of routine socket preservation with using a resorbable membrane? Who uses resorbable? Yeah. Anyone else uses resorbable? No. Who uses a non-resorbable membrane? And then who uses nothing on top of the bone graft? No. Yeah. So with bone grafting, it's important to get very good bone contours for your implant placement. And what I mean by that is, a lot of the time, if you just stick some bone graft in there, and let's say you just place a piece of collagen or a piece of PRF over that, the collagen will resorb, or the PRF will resorb too fast. So you're always going to get this little bowl-shaped defect on the top of the ridge where the implant is. Now you have to place your implant deeper, right? But if you place your implant deeper, now it's hard to clean, right? So there is such thing as placing an implant too deep, right? Like mucositis' definition is more than a 4mm pocket plus bleeding, right? We don't want to start off with mucositis around the implant. We want to have it at the proper depth, right? So I'd say 99% of the time when I'm removing a tooth, I'll do this. So I'll take the tooth out, right? You have a flap underneath each side. I just do an envelope, so I'll go down and release the tissue from the bone with my boozer elevator, and you guys are going to get to know that instrument really well this weekend. And then for hard to reach areas, I won't put a vertical flap down, I'll go in with my curette. So go into the curette and release the tissue more, okay? Now releasing on the palatal side, it's very important to lift that tissue up at about 4 to 5 millimeters. Some of the articles show 2 to 3, but the membranes will become dislodged and bunched up if you don't smooth it out or reflect enough. So don't worry about reflecting. Make sure you do at least 4, 5, 6 millimeters. Then I'll pack bone. This one's like a 50-50 cortical cancellous mixture. Now if the buccal bone is missing, I'll do like a 70-30 mixture. So do cortical cancellous plus some xenografts. So add a 30% just for space maintenance. That way the body doesn't resorb it too fast, right? And it will turn over eventually. Then I'll put PRF over the top of the bone, and then I'll tuck that in the buccal and the lingual. Okay? That'll help get a nice clot going for you right in the beginning. Then I'll stick a piece of PTFE. Cytoplast TXT200 is what I use. It comes in 3 different sizes. There's like a 12 by 24, 12 by 30, and then a 24 by 30. So I stock all 3 because if you have a buccal bone that does snap off, you can tuck that 12 by 30 piece down the buccal bone and pack bone against it, which is awesome. Okay, then you can flip it over and tuck it under the lingual. And then you'll tuck it buccal lingual, and then we'll suture over the top, like this. This is just my gold standard way. I've probably done this thousands of times at this point, and I always get a good bone graft. It's great. You don't get the bone loss at the top. So I just say caution when using resorbable membranes, only because if you don't get more of a primary closure, resorbable resorbs away. It does. The only thing that doesn't is a bioexclude. Bioexclude is something that you can't leave exposed to the outside environment, and it does not resorb away. Okay. And if you use something like a pericardium, that's my favorite one for resorbable. That can only be left open by 2 millimeters. So you have to release that periostum to close it, otherwise you get bone loss in the beginning. Okay, so. Yeah, just those 3. Yeah. Maybe graft like number 4 or something. Yeah. Any questions so far? I just want to kind of give you guys just my straight and easy protocol that I follow for grafting for every single case. This is one with a molar. So you took out the tooth, big hole, right? This one actually the bone graft or the buccal was gone. So let me show you this one. right here. You should check out this too. Look at that buccal bone loss, right? Pretty substantial, right? And you can see that little tiny piece of bone that's left right at the cortex. So same thing, pack bone. And then this one I used a PTFE, a longer one, a 12 by 30, and then I tuck the PTFE down the buccal, pack bone against it, and then you flip it over. Okay. Here's another one. Look at the size of this hole, right? It's gigantic. Same thing. So these, I want everyone to get good at releasing tissue this weekend. I think it's one of the most valuable things you can learn in surgery. Not only the implant process, but how do you actually achieve like a tension-free closure? And that means, let's say if you're using a cover screw, right? Inflammation alone is enough to open up an incision, right? Because if you just reapproximate edges and you don't have any type of release, you can still get incision opening on the top of your cover screw. And I think this doesn't get played on enough. Because as soon as you open up, as soon as a small opening happens, you get a little fistula, right? And then how do you nurse that along so you don't lose your implant in the beginning? That's why I'm one of the biggest supporters of using healing abutments or using them correctly. So we're going to go over a ton about that this weekend. I also have quite a few videos on YouTube that I've done on like healing abutments, cover screws, just kind of breaking down all these little topics for everyone that are free resources for you guys too. So for something like this, I actually just released the periosteum. So I go underneath the tissue about 10 millimeters with a curette, and I just pull up, and it just tears the periosteum. And look at that. I can already get closure just by stretching the periosteum. And by doing that, you're going to get so much better closure. So this one is more of a sticky bone, and then the size membrane was a 24 by 30 is what we use. And then so you got bone, PRF, one PRF over the site. Then you'll pack your membrane over the top, then you suture. So that's just what I've always done for my grafts. Any questions on grafting techniques? I know we're not going over too much, but.
Leave your membrane for 4 weeks?
Yep. So if the buccal bone is lost, I would wait 5 weeks. Now, sometimes what can happen is if you don't tuck your membrane down enough and it lifts up, the reason that these non-resorbable membranes get a negative review by some docs is they don't tuck it underneath and they say, oh, it releases, it comes out. It doesn't come out, we just didn't tuck it down enough, right? And then that thing will just not pop out. It's fantastic. So I would say buccal bone that's gone, I would wait 5 weeks. I would go 1 week, and then I see them at about three weeks out. And I kind of make a determination, like, is this looking pretty good, or is it going to, does this look like it's become immobile, right? And if it's looking really good, I push them out another 3. If not, then I see them 1 week and just pull it out real quick. So pretty quick visits, they're like 30-minute visits. And then you get all your keratinized tissue back, right? That's the most important part. So you're not moving the gingival zenus, right? You're keeping the gum tissue where it is. And now you have just an infinite amount of keratinized tissue on the top of the ridge. A lot of Perry articles show that like the best amount of bone and tissue in front of an implant is like 4 millimeters of bone and 4 millimeters of tissue. That's impossible, right? That'd be a crazy amount of biology. But if we can get 2 millimeters of bone and 3 millimeters of tissue, oh man, that's going to be a very long-lasting implant that we're never going to have complications with. So the membrane, I do 250. It's like 250, 251. A Cytoplast one costs about $45. They are billable to insurance. So my typical socket preservation, I do extraction. Usually it's a surgical, usually. Then you'll do a membrane, non-resorbable membrane, or resorbable depending upon the code of what type of closure that you think you can achieve, right? And then bone graft. Usually that price is around $750. And then PRF. And that one you can decide if you want to charge for it or not. I believe it helps with really stable clot formations and wisdom teeth and over all my arches, and I love it. Yep. So not every state actually needs that type of like certificate. So I say it's just really just state dependent on it. Like some states, they let your hygienist do shots without licenses. Some just don't let your hygienists really do anything, right? It just depends on the state. I actually have a phlebotomist as an assistant, which is freaking awesome. So now I don't have to do it every time. But I did it myself in the beginning because if your assistant misses, you have to do it. Yep. No, she came in with phlebotomy trained. Yep. Yeah. So like as the evolution happens, you want to try to hire like a surgery-based assistant a little bit, like one that has phlebotomy. Oh, it's gonna make your life so much easier. It's fantastic. It's a different level of thought process, right? That an assistant has to.
I've done the non-resolvable membrane over, but never on the buccal. How do you remove a buccal membrane if once the tissue, because by then the tissue's kind of closed up?
Oh, you just pull it just like that. Yep.
Does it come out on top like?
Oh no, it's just all one piece, and you just pull the whole thing out. It hurts less than a Band-Aid, for sure. Yep. It's pretty quick. So like, it pulls right out. And you see all this like beautiful like immature tissue at the top of it. Such an awesome thing to see. It'll show up like this, right? You get like a little bit of immature tissue just at the top of the ridge, right where it meets the tissue, and it's becoming more thick again, whereas where it's thickening. Okay. Any other questions besides just about grafting, just generally? I just want you guys to start having that thought process, because part of placing implants is you're not gonna be able to place an implant unless we have like good grafting first. It's so, oh my God, it's so crucial here.
Remind me on those PTFE membranes,
Mhm.
you want the smooth side exposed to the wall cavity?
Good question. Actually doesn't matter. Yeah. But it's the shiny side up, I think. No, the shiny side goes down on the blood side. So it's like the dimple. So think of it this way: the part that's slightly more textured with the bumps, the tissue wants to like creep on over it. Think of it like that. So shiny side down, the slightly bumpier side or matte or bumpy. If you feel the texture of it, that's the side you want to place up near the tissue, because the tissue kind of creeps up on it. Is what it does, or at least that's what they say it does. Yeah.
But it'll work really well.
Yeah.
So I've never done like this type of bone grafting, but the
Mhm.
practice I've always looked at, they just have this little osteotomy
Mhm, mhm.
spire in there, and once, I assume they're not nearly as good as doing this. But
So that will turn into bone eventually, but it'll take 10 months. 10 to 12 months, I'd say. So if it's a routine socket preservation, all the walls are there. If you use one of those, that's cool. I would probably wouldn't go place the implant until month 6. It's just because the bone is just not bone yet. You know what I mean? And with a lot of these buccal deficiencies, you just won't get that volume back, and it's going to take at least a year for that thing to remodel enough for you to use that site. So that's why cortical cancellous is just like gold standard. Been even if you think about Europe never even used allograft materials up until like 5-6 years ago. They just always scraped bone and put auto in. So. Now, I would use that type of bone graft if you're doing it for a patient that maybe economical reasons, where we just want to prevent a dry socket, but their implant is not going to be placed until maybe a year later. Then fantastic. I think that's a fantastic idea. Infection prevention and bone loss prevention, right? Because if no bone graft, you do lose between 20 and 50% of bone in those areas. That's what all the articles say. So if you have a 5-wall defect, I still bone graft it, right? I just want all the tissue, and I want all the bone. Is what I want. Yeah, really good question on that. There's a couple of newer companies out there. One by, let's see, Osteogenics has a new one that actually expands in the socket, which is kind of cool. But then it's like, then we're just arguing about maybe like another month's recovery of that plug, right? When really the gold standard to get an implant in is using cortical cancellous. I'll routinely go into sites by week 10. If it's not a giant graft, I wouldn't advise doing that. Do it month 4. But nowadays, the bone grafts heal really well, and I treat it slightly more like a immediate implant than a super healed ridge. But in the beginning, wait 4 months to place your implant. So do your socket preservation. Wait till your tissue comes back and the bone comes back, and then place your implant. So just don't get into trouble by doing things too soon. I've definitely made some mistakes along the way. Cool. I'm gonna move on to implants. Is that cool with you guys? Yeah. Cool. Okay, so let's talk about like the depth that you place an implant. Now, again, this depends on the implant you're placing, right? So if you're placing a Nobel, right? Megagen. Who said Nobel? So Nobel. Okay. So Nobel is going to be right. You're going to place that implant a millimeter below the bone. That's it, right? So we're going to teach this week. We're going to teach on neodent. So we're going to teach about more conical connections like a Megagen, right? Or like a Han. But just remember for this weekend, you still biology does matter, but because of the connection, you don't want to place it too deep because you could cause more bone loss or remodeling during the first few months. So like a millimeter below the bone for you. Yep. And then by horizons, right? Which implant are you using right now? The taper. Okay. Okay. So same thing. 1 millimeter below. Yep.
What about the Straumann?
Straumann's are their degree of taper. I think is 15 or 16. I have it in here. I think. So it's the same as a neodent one basically. Confirmation. Yeah, Straumann's 16 degree taper. Neodent's 15 degree. Yeah. Yeah. Yeah.
Lewis is back. Don't tell him I said.
Yeah. He was just cursing about biohorizons. Don't worry. Don't worry. So the amount of the implant placement depth does matter quite a bit. Now, a lot of these articles show you can place it up to 4 millimeters, but I would never do that. So the reason is you still have a soft tissue height, right? So what happens if you have 2 millimeters of soft tissue and 4 millimeters of bone? 6 millimeters, right? That's a lot of biology above it. The only time that I would place an implant that's deeper like that is if you're placing a multi-unit at the same day of the surgery, or your abutment the same day of surgery. Because there's this idea of abutment integration that Neodent, one of the owners, came out with a long time ago, and basically showed that the implants are so stable that the bone adheres to the smooth surface because the connection is so stable, right? But you don't want to. That's not going to happen on your onesie twosies, right? You're gonna have way more sources of infections because you're taking things on and off. You're taking your healing abutment on and off, right? The hemidesmosomes that attach to those healing abutments and those smooth surfaces, they become annihilated, right? At some point in time because you just keep removing those things. So vertical soft tissue height. Minimally, you want 3 millimeters of vertical soft tissue height to avoid bone loss. So think of an implant as a crown prep, right? A crown prep, you have biological width. An implant, you also have biological width. It's the exact same thought process. So you want, they say 3 millimeters of biology. I recommend 4, and by biology I mean above the implant you want bone and tissue, doesn't matter which one it is, but you want 4 millimeters. So if your tissue thickness, the average tissue thickness is 2 to 3 millimeters, okay? So that means your average implant is going to be placed 1 to 2 millimeters below the bone, okay? So generally speaking, I'd say every implant that I place is about 1.5 millimeters below the bone. Because there's always about 3 millimeters of tissue. So I think that's pretty good. And remember too, the deeper you sink that thing, the harder that it can be to restore. So I think some of the parts on the key items about these conical connections, about placing them deeper, there is this thing is too deep. So I just want to point that out because I do notice I get some x-rays back from students and they're placing them a little too deep. So I say, hey, let's just caution. Let's place them like 1.5 deep. Okay. We have the biology that's above it. Any questions on like biological width of an implant, like what that means from any of our videos, or everyone understand what this is? Yeah. Any questions on how much bone, like the proper depth to sink an implant, or any questions on the soft tissue above an implant?
So are you saying that it doesn't matter the implant system, it's always going to be factored in the biological?
Exactly, 100%. Yep. Because your average case, if you place an implant 1 below, you could still get the 4, right? Because a lot of cases do have enough tissue thickness. And what I've noticed over the years is the problems that I have, the area that I most commonly get bone loss on is the posterior maxilla, because there is a lot of time on these edentulous ridges, the bone around the top of that ridge is really thin. It's like 1 millimeter thick.
right? Or let's say a lower one. If the tissue thickness is actually 1 millimeter thick, then we're prohibited sometimes by vital anatomy, like the sinus or the nerve, where we can't place the implant deeper. Therefore, we settle with placing an implant even with the crest. Then the biology attacks the implant and we get bone loss, right? So what I've actually changed in my protocol since Neodent came out with the short helix, they have a tissue level, and I don't really use it for the exact reason that they came out with it for, but I use it for thin tissue type cases, is what I do. Because you're elevating the restorative platform and you're making sure that biology can attack that implant. So it's like, right, does that kind of make sense? Is that the biological width is not there, body will create it. So how do you prevent the body from creating it? Is by using a different type of implant, by elevating that restorative platform. So nowadays I'll use a short helix, and I wish they had a 10 millimeter one. I told Cliff that would be really nice. And not call it short, just call it like tissue level helix or something. That'd be really cool. Because sometimes you need something taller than an 8 millimeter. But tissue level implants, they do have a home, I think, in dentistry still. I think if I lost my first molar, I would actually want a Straumann tissue level implant. They have some big ones, and those have one of the highest success rates in implants of all of history. It's like 99% batting average for these things because they don't get bone loss. You can't get bone loss around that smooth collar surface, and the soft tissue loves it. So I want to challenge your guys' thinking just a little bit and have you guys learn about all these different types of implants and understand like where it fits in, where this implant fits into the game. Any questions on the smooth surface of like an implant like that? Like why it would be better or worse in those scenarios? Does that make sense about the thin tissue? Like why my brain would think that way? Because if you can't sink it, right? If you can't establish that biological width, or I'd say my first 20 implants, I was so happy I created a hole, right? I was like, yes. I was like going around like high-fiving everyone. It was like I drilled a hole, the implant's like even with the bone, and then I got 2 millimeters of bone loss. I'm like, oh man. And then it's like if we would just place the implant a little bit deeper. But what happens is implant goes down and it might be too stable, right? We're like, oh, I don't know if I can get this implant down, so we settle for that result. Don't settle for anything in the beginning. The best part about implants are they're removable. You can unscrew it. You can tell the patient, I'm sorry, your bone was not very dense. I just couldn't place the implant today. We're going to graft it. We're going to do it again, and it's going to be fantastic, right? Something easy like that. But where we get into issues is when we settle for that less than ideal result, okay? So while I'm going around all the rooms this weekend, I'm going to be checking all of these things, right? Where's your depth? Where's your buccal bone? I'll be very honest with you guys, like on how we want things to look, because the last thing I want you guys is have an implant failure go home. I'd feel terrible if I didn't give you guys a good leg up here. So you had a question about tissue?
So with the tissue level,
Mm-hmm.
thin tissue, the body would naturally create that extra keratin
If
or that attachment?
Well, if the tissue is abnormally thin, right, that would mean you'd have to place your implant deeper, right? Now, if you can't place your implant deeper due to the implant being too much in the sinus, or the IAN nerve is right there, then the body will attack that implant and cause the biology that it needs to be successful, right? Therefore, you start off with like a millimeter of bone loss. If that makes sense. Does that make sense? Yep. So how to combat that is in those unique type of environments. If you place a soft tissue, if you saw a tissue level implant, the thread will be at the bone, but the tissue adheres to the smooth surface collar, right? And now you can't get remodeling. Yeah. Yeah, of course. Now attach gingiva around a dental implant, 2 millimeters, minimally. Like over the years, you're going to see some implants that you placed, and hopefully they're not ones that you did soccer preservation on, right? Because if you do soccer preservation correctly, you get the tissue back, you will never have these issues. But it's usually on this type of issue is usually on an implant like 29 or 30, where it's a distal edentulous ridge that the patient has been missing that tooth for a very long time, right? So just make sure your incision splits it right in the middle between on the mandible when the tissue is thin. Split with your 15 right in the middle, right? Because you need some on the buccal and you need some on the lingual, right? So give yourself at least the best bone and ground. Now, if you don't have more than 2 millimeters of attached tissue, Eventually, you could have to do a soft tissue graft, okay? But there's usually a couple years down the road. We'll just recommend just pay attention to your incisions right now. And if you have some vertical tears during the surgery, just keep in mind that if you have a vertical tear, don't suture the vertical tear to the front of the implant, right? Just keep in mind, like, picture where that keratinized tissue is. Sometimes I'll suture that vertical tear first, and then I'll suture the keratinized tissue around the implant, if that makes sense. And I do the same thing with all necks, because if you end up with like mucosa around your implant, you're gonna get bone loss, right? So just keep in mind, soft tissue is very, very important. And I'm not gonna cover this part yet, because a lot of the time we're gonna just do, I'm gonna share with you guys actually my lab slip. I have a really good lab slip for implants. I'm going to share it during the Neodent like growth summit too, because I'm doing a presentation there. I'm going to share that with everyone so everyone can see those things. But I'll give you guys my lab script, what I like to say in it, and the X-rays that I send, and why we send it. Okay. But let's talk more about the surgery. Let's do, while we're here, I want to kind of not talk a little bit about the implants themselves, so you understand about thread, like a little bit more about like thread design and why, like what we're placing and why we're placing it, because it really matters. I thought a screw is just a screw. It's really not. So let's say helix implant, Neodent helix implant. 99% of cases I place this for. Then they have a drive implant. So there's some very key differences between the two. Now, it's a tapered implant. It has the tip of it right here is more knife edge like threads, right? Then when we get about a third of the way up, it switches from the more the knife edge to trapezoidal threads. And the reason is when you put this implant in, it'll kind of pull itself in the first third. Then it starts to compact the bone, which is awesome. So it goes in, then it compacts it, if that makes sense. Now, a lot of problems with implants, like a Megagen, their thread design, or BioHorizons, they're too knife edged. So when you're putting the implant in, it just keeps going, but it never actually torques out at like more than 50. So the reason why I've liked this implant so much is it is always stable. It's fantastic. Almost too stable, right? So just don't get scared this weekend. We'll show you how to properly prep the osteotomy to make sure that doesn't happen to you. But this is a real thing. In arches, a lot of the big full arch world, right? I have only never loaded 3 cases, I think now, over like 600. And the reason is of that implant and the key principles of like engaging cortexes. Like how to engage the nose, or understanding soft bone. Like, what is soft bone? Is the bone dense or is it soft? Okay, we'll go over that in just a second. So key things that you guys are gonna pick up on this weekend. It's crazy that we don't learn some of this stuff in dental school, right? So once this thing goes in, it starts compressing, right? Now, this apex is cutting enough so you can always just make that thing go in. It's like a screw, you're hanging a TV, right? Now, Neodent has a drive implant. Their drive implant is way different of a design. Now, the entire implant is compressive, okay? So the threads are squares throughout the entire implant. So this is not like an implant you place for your onesie twosies because it's too stable, you won't get it down. The rounded apex is not meant to cut bone, it's meant to compact bone, like as you're placing the implant in. So I see some docs placing this implant in a D1 or D2 bone snare, and they're like, oh, this implant's great, I always get stability. I'm like, you're like over torquing this implant. Like, you could break the implant or break your driver, way higher risk for some complications, so don't use it improperly. This implant is a rescue implant for me. I use it for D3 bone or D4 bone when I don't get stability for my helix, is what I use it for. It's like a rescue, it's a last resort type of thing. So I want everyone to get really good at placing a helix, right? You're placing it using the one that we want to use that has an active thread design, right? will self-tap itself in, but also has compressive. And then we'll save the ones that for the more D3, D4 bone case scenarios for the Neodent drive implant, which will just compress, right? Because it has a rounded apex, not a cutting one, and the threads are square. Does that make sense? Yeah. Any additions by the Neodent people in the back?
I would say just to remind you that even though they're two different designs, they still have the same prosthetic.
Exactly. So the prosthetic platform for Neodent's Helix or Drive or Titamax, right? Or their Helix Longs, which is like a pterygoid implant, or their Zygomas. They're all the same connection. That one is. The one that's different is the short Helix in terms of the driver, and then their narrow implant that they have. So they have a 2.9. So it's like the whole portfolio. That got me caught. I placed some 2.9s like last year in October. It was like couple of the first ones, and my rep didn't know that the healing button was different, and I like that. I like got the surgery day. I was like, oh shit, like, I don't have a healing button, but I have a friend that had one, so I was good. But I was close call. I was close call.
The beauty of both of those, though, the narrow and the short, is we're the only implant system out there that you can use and adapt those in for overlifters as well as core.
Yeah, true. Yeah, the prosthetic parts are switchable. Yep, true. Any questions on the two implants? Any questions on the two types of implants? Or just like thread design? I just want everyone to visualize this, because if you're going to buy an implant, understand the thread design. It's really important because that's going to dictate how well your surgeries go. It will. A lot of arch centers, they don't use like a BioHorizons implant, like the tapered one. They use it for singles because it's great for singles, right? Like the laser lock and such good principles. And everyone acknowledges that. It's a great implant. But if you're going for D3, D4 bone, right, you might not get stability. That's the problem. And also think of an implant as one where if you're going to place it, you also have to think about removing it, right? So have you seen the size of some of those megagens? Not the blue one, but the other ones. Do they look like freaking linebackers in the bone? And then imagine losing that implant and having to take it out or try finding that thing out. You have a giant freaking hole now. So that's what personally worries me. I want something that goes in, but I can also take it out, is my thought process. Because that way I can place another implant if the patient needs one in like 15, 20 years, right? If that ever happens, God forbid. And these are the two implants, like a picture of it. So you can see only round here. And then you see the cutting starts right instantly. Okay. Actually, let's go back to this. Now that I gave you guys that, I want to talk about bone density. And then we'll kind of lead into, I'll talk a little bit more about the surgery portion. And then we're going to talk about our drilling protocol, I think. When's that? Drilling protocol. Cool. All right, so there's all sorts of different types of bone, right? So we have one all the way to the left. That's going to be more D1 bone, okay? D2, you're going to see more of a thicker cortex, but the inner looks a little softer, kind of looks like a sandwich, right? And your D4 bone scenarios are the sandwich and then a dark hole on the inside, right? There's a substantial difference in how you drill, right? The key, the goal, what we are trying to achieve is more bone around the implant, right? If you have more bone around the implant is more secure, right? So at what degree do you prep? Like what would be your last burr, right? If you're placing a 4.3 implant and your hole has no bone, would you want to prep to your last burr for a 4.3? No, right? So, but if your bone is D1, D2, sometimes D3, would you prep to your last burr? Most likely, most likely. So I think part of implants is, in the beginning, I didn't even realize that there was this such thing as softer bone and harder bone, right? And this gets missed a lot. So while we're placing implants this weekend, we're gonna want you to ask you guys, like, hey, what type of bone is this, right? Like when you look at the CT, is the CT which one of the three, right? That's your first sign. Your second sign is during your drilling, look at the bone on your flutes of your burr. This is something that I do a lot. So if I don't know how soft the bone is, then I'll drill a little bit slower. I'll take the burr out. I'll look at the flutes. It's pretty cool. So I'll actually drop my speed down. So you can plug your ears just a little bit. So sometimes I'll drill slower. I'll drill 50 Newton centimeters at 50 RPMs, just enough to get the burr to go down. I think in the beginning, and even now for me, if you drill 2,000, you're just consistently just blowing away the bone, right? And you just don't have that tactile feel, right? Like you're doing a crown prep or you're doing an endo, right? Everything is such tactile abilities when we're learning in school. So building the tactile feel for bone is so important, because some of these, if you go, for example, look at this one. What happens once we drill through this cortex? What do you think would happen to the burr? The burr would probably just push right in, right? And that's what happens. So a lot of these. So the reason I drill slower and some of these on the really soft cases is to just understand if my burr just falls right in, right? And my goal is to leave the bone inside the osteotomy and to not drill it, right? To just push it and leave the bone there rather than taking it out, if that makes sense. Does that make sense to everyone a little bit? Okay, cool. So in Neodent, when they made their protocols, they were really smart. And they said in D1 and D2 bone, they say 800 to 1200 RPMs, right? I have all the motors set to 1200. And the softer bone, they say 500 to 800, right? Because they understand same thing, same process, that you have to drill slower in soft bone to understand how soft it is, right? Because I want everyone to have a stable implant and not get a spinner, right? Now, will a spinner heal? Yes, but when, right? Like how long will it take? The hardest part about knowing that answer is how are you going to measure that, right? How are you going to measure that now that when you go to actually check it, it doesn't just spin on you, right? So will an implant spinner heal? Yes, but wouldn't it be safer for us to achieve stability on every implant, right? And by stability, I mean 35 Newton centimeters or above is what I would call stability. And I think it's 100% possible. And I would place a healing abutment on anything that's 35 and above in the beginning, just to be safe, okay? And it's something under 35, I would place a cover screw for now, okay? Also too, in one, I'd say our first like 50 implants, it's hard to really identify exactly how much stability you have on your implant. You may think it's 45, but what if it was really 35? And for me, when I placed my first 20, I was so excited to go it in. You know, sometimes I might add on another 10 Newton centimeters. So the assistant will be like, hey, what stability was that? And it was really 25. And I was like, oh, it's 45, right? Because we want to believe that it was a good result. But the hardest part is to just be objectively honest with yourself, right? Like how do you stay honest with yourself? And if you're honest with yourself, you're going to achieve so much better surgical results if you're just humble, right? So humble, realizing when you drill too much, right? And when you get a failure, blame yourself first, because it's usually not the patient. I feel like we always blame the patients. Maybe that's one of my soft spots, but I'll never blame the patient. I might tell them that their bone is soft, but internally I'm thinking, man, I did something. What did I do? So I'm always taking an x-ray and an intraoral photo of the soft tissue at every single post-op, because you're gonna start building this Rolodex in your brain of why something failed or why you didn't get stability on something, right? Maybe it was a suture, maybe you drilled too much, right? There's always something that we could apply that surgical error to, right? A surgical error, not a failure, I'd say surgical error, right? Is what it really comes down to. Yeah.
You do the osteobeacon?
The what?
The osteobeacon?
No, you can. So what he's talking about, you can buy a device to read the ISQ value, right? The frequency of the implant to measure whether the implant is stable or not. Now, yes, that's super helpful, but still the biggest predictor is your stability in the beginning, right? In the 80s, the 90s, they qualified a successful implant as an implant radiographically with no radiolucencies and no bone loss, right? So we're looking at, I like to think more old school measures rather than buying a device to tell me what I should have known during that surgery, which was the stability, right? But it's a very fantastic piece of equipment to use to give you an objective measure to something that can be very subjective, because we may not just know that answer yet, if that makes sense. So definitely highly advise using something like that, or for like litigious reasons, right? That's cool too, but still, biggest success is going to be making sure your implant is stable, right? Therefore, you don't have to keep waiting for it to heal, right? Because some of these you have to wait 6 months. That D4 bone scenario, I wouldn't touch that implant for 6 months. It's just bone won't grow around it enough. Does that make sense to everyone too? Yeah, like super valuable things I wish someone told me a long time ago. And when we're drilling this weekend, I like to use my favorite burr to start the osteotomy. It's not in the kit. Right here. So this picture right here, this is the Vatek one, and then right below is three different drills. The one on the bottom, or the top, sorry. The top is Neodent's 2.0 twist drill, okay? The one in the middle is the 2.0 lance, okay, from Neodent. The one below it is a 1.5 millimeter burr. So I like to call this like my precision burr, okay? And the reason is the tip of this creates a way smaller hole than that, right? It just does. And if we can start every osteotomy just being correct on the correct place on the top of the ridge, then as we're going down the bone to increase the diameter, right, you always want to start off in the right place. And if you are wrong in your location of your pilot drill and you start off with that 2.0 twist, now your hole's this big, you're correcting it, now your hole's this big, right? But if you have that little lance and you can make a little hole and you're wrong, you just drill a tiny little hole again, right? You can do it 4 or 5 times and you can be wrong and you're still going to be just fine. So I just want to encourage everyone to get the implant in the correct dimension on the top of the bone, right? Before you go down the bone, right? And as we're going down the bone, work in increments, increasing in size and diameter so that by the time you get to like a 3.5 burr, that burr's spot on, right? Getting those habits early on is just very, very important. That one I get from Blue Sky Bio right now, but you can find one probably for cheaper somewhere else. But it's very sharp. Just be careful this weekend. If you touch the tip of it, you'll probably poke your glove. That's how sharp it is. And the sequence of that I like to go in is I like to do the 1.5. Then I would put the lance in. Now see how the tip of that 1.5 lance is sharp? It's more narrow, right? That'll go inside the hole of the 1.5. Then as you're going down with the lance, the middle of that 2.0 lance will fit the 2.0 twist, right? So it's like you're sequentially just increasing the size and the diameter of something that when you're drilling. Now also look at the difference between the two drills, between the 2.0 lance and the 2.0 twist. The 2.0 lance has no threads on the side, right? So this is something that we're really just we're gauging. We can push, right? We can even do pushing to see if the burr just goes in all the way, right? It's like a push test is what I like to call it. So you have your CT and then you have your burr to do a push test and see how soft that bone is, right? Then if you need to make dimensional changes, right, after that, you can use your 2.0 twist to move the osteotomy around, kind of like you're doing a crown prep, right? So you just kind of move it around in different directions, which is awesome. So it's a lot like restorative. It's interesting. Surgery, actually, it really is. It's like cutting a crown. Bone cuts just like a tooth does. Actually cuts a little bit easier. Any questions on those drills? Like why I would use them in that manner? Just precision. Think always like, I want to be spot on, but I want to be spot on in the beginning, right? Rather than in the middle. Because if you go too far down the line, let's say you get to a 3.5 and you have to change the bodily motion of the implant like quite far over, you're probably not going to get stability now, right? And we're going to have to do a cover screw. Is there something wrong with that? No, it's going to heal, right? But again, it's when is it going to heal? So now we'll wait that 4 months or that 6 months, depending upon the stability of the implant. And if you drill a little bit slower like I do, when I'm trying to figure out what type of bone it is, so let's say you get to that 2.0 twist, right? And you're going to go to a 3.5, and I'll turn my motor down to like 50-50. So it's 50 RPMs at 50 Newton centimeters. So it just goes like this. And it cuts the bone perfect. And the only bone that it doesn't cut is like D1 or D0, like, right? Like it's so hard, it's like a freaking cortex or a rock. Obviously, I can't cut that rock. but it will cut everything else, which is great. Then you pull that burr out and you just look at the flutes. And if the flutes have white bone on it, it's D1. If the flutes have just blood on it, it's D4. And in between will look like this picture to the left. It looks like red and white bone, or just red bone is what it'll look like. That's somewhere in between that range of D2, D3. Now between D1 and D3, those are the times where using a helix is going to be perfect, right? And you're going to get stability, and you're most likely going to have to use your last burr. But on some of these cases, if the burr comes out and it looks like this, right, there's not much bone touching your implant at this point. So our brain should start thinking, like a light bulb pops off and say, this is soft. Maybe we should try using our last burr by under prepping by 1 burr. So therefore, if I'm placing a 4.3, the last burr could be a 4.0, right? Or some scenarios, it might be a 3.5. But I would say in the beginning, just under prep by 1, okay? And you start getting a feel of the implant, start getting a feel of the drills, and if they just push in sometimes too. Questions on that so far? No? Yeah.
For the D4,
yep.
Under prepping by 1, would you ever just automatically go from helix to the driver?
I actually do. Yeah. I had an arch. I did this FP1 case on Friday last week. And I had arch on the top, bottom had 4 implants on the bottom. And it was just like this case. It's just like this one. So what I did was I just prepped the top of the osteotomy with just the first 2 millimeters with a 3.5. And then I put a 5x10 drive-in. And I got 15. I was like, yes. I was so happy I got 15, like, right? Like that, I thought that was really awesome. It's gonna heal just fine. But some of those, if you push that 3.5 down, it's just you're gonna put it in and you're gonna lose it. The implant could just disappear on you, right? So it's really important. I just want everyone to just go off in your brain if you see this type of implant, that scenario. It's pretty rare, to be honest. I'd say maybe 5% of the time, I think, is what the literature was saying when I did this presentation and looked it up. But it is out there. But it will look it'll look just like this. The sandwich on the outside, and the inner just looks just completely dark. Just air, basically. You almost call it D5 bone in a way, right? Even that's not really a category. Questions on that? But interesting, right? Now remember, 95% of the implants, just like 95% of wisdom teeth, because that everyone in this room can take care of. But the ones that I want you to also pay attention to are the ones that can get you into trouble, right? That way that doesn't happen. Someone had a question? Yeah. Yeah. Oh no, just shoot us a text. Yeah, yeah. We're having like a platform coming out we've been working on for the past 6 months for this type of thing, where you guys can post questions, like an actual community. Because now we've had 20 events and we have a lot of people, and I want you guys to have those questions answered. But the trick is you have to reach out to us, and I promise I'll answer. Yep. Yeah. Yeah. Yes.
If you have very thin bone, when you go in there with your pellet drill, you're going to have a lot of blood. So in that case, when you go through your sequencing, you wouldn't reach all the way to the end, or you wouldn't reach the end.
You wouldn't reach the end of the sequence for the burrs. Yep. And now let me pull up a picture of the kit.
And the reason behind that is because if you do reach it, then you're not going to have anything.
If you reach it, that means that you cut bone, technically, with the burr. And if you cut the bone, now there's less bone around the implant. Therefore, you have a decreased amount of bone to implant contact. So the goal is to have as much bone around that implant in soft bone scenarios, so that that bone adds stability to the implant. That way when you put it in, it's stable. It's like hanging a TV in a 2x4 versus hanging a TV into drywall. Like when you miss the 2x4, you're like, oh crap, the stud's not there, right? Then you go find the stud. But this is that same scenario with it, because like in drywall, you'd have to go get a drywall anchor and do something different, right? Then completely different. So that I want you guys to think about that the same way with implants and bone density is if you drill too much, it's a surgical error. Will it heal? Yes. It'll be just fine. But when will it heal is the question. So if everyone gets really good at in the beginning, and everyone starts in the beginning here, so awesome. So you guys pay attention to this. If you start to understand bone density, now you will never have these issues. It's awesome. You'll have, and it's quicker implant placements too. If you can like push an implant in, push a burr in, and then drill like a 2-minute hole and put an implant in, and you get stability. You're like, man, that was fast. Go back, drink your coffee now. Right? Do your hygiene checks like me.
If you have the room for it and you don't have stability, would you rather place a bigger implant than bury it?
Yes. Yep. I do that as well. So if you have an implant, let's say, and every implant when you're planning it, you never want to plan for the biggest implant for the site. So the thought process used to be place a big implant, right? But now it's not like that. We think of implants in terms of bone to implant contact. Is there enough bone around the implant to be stable and have long-term stability? And the sizes of implants that have really good bone to implant contact are a 5x8, a 4.3x10, and a 3.5 by 11.5. All three of those implants have the same amount of bone to implant contact. So if you're going to stock implants in your practice, do those three, right? Because they have the same amount. Now, once you start going down on the scale of bone to implant contact, right? When you go 3.5 by 10 or 3.5 by 8, right? Will they integrate? Yes. But could you remove them? Yes. You could take a driver to a 3.5 by 8 and just unscrew it. Could I unscrew a 5x8? No, not a chance. Like you have to drill out enough of bone to be able to unscrew that implant and to dislodge the stability of it, if that makes sense. So me, I think about an implant as I would love to place that implant if I can't take it out, if that makes sense, right? Like if your hands can take an implant out, is that stable forever? Not really. So I tend to graft areas to get the proper implant size, if that makes sense, rather than going with a product that's just too small. I removed so many implants over the years, and now I just think like that. I think when I put an implant in, I was like, well, I could actually remove that with my hands. I get a little concerned about just 20 year on that implant, right? With all the chewing forces, is the screw hole lined up properly for the prosthetic, right? Like all those little factors now are really important. Otherwise, you could just have a very strong implant with lots of bone to implant contact around it that will never fall out. That's how I think about it. Questions on that at all?
Can you go over your dense bone protocol?
Yeah, yes. This is perfect. This is exactly what led me into this conversation. This is exactly what I want to talk about. So let me pull up this one now. Huh. Oh, there it goes. That's funny. So we have our drilling protocol. Obviously, it's called Black Diamond because we're in Colorado, right? We've got to name something out of the ski mountains here. I'm a big skier. So this kind of goes into that sequence that I was talking about. And this is the drilling protocol. I want you guys to, you don't have to stick with this, right? There are manufacturer reasons why they have different protocols, right? But the reason that I made this is to just keep your eye on density. Reasons for density, figuring out bone, and how to get stable implants. But then what do you do if it's not stable, right? All right, so if we were placing an implant that is 10 millimeters tall, what would you drill to for the depth? Does anyone want to guess? What's that? 11.5, pretty close, yeah. So I think of an implant, there's this word called depth. The implant depth is the implant plus 2 to 3 millimeters. And the reason is, obviously we're not going to drill into the sinus if we don't have to. We're not going to drill into an IN, right? We're only going to drill for a little bit extra room when we need it. Because if you're placing an implant, a 10 millimeter implant, you're drilling to 10, where are you going to get to the bottom of the osteotomy where the implant's going to go down? No, right? If you're going to place an implant 2 millimeters deep, you have to drill to 11.5 to or 2 or 12, right? And if you have the running room, just give it an extra millimeter. I do see a lot in D1 bone scenarios where the doctor is drilling an implant and they say, I lost stability. And it's like, huh, interesting. D1 bone, you lost stability. How's that possible, right? It's because they drill too short, too narrow. And because the implant reaches a concrete stop, it just goes down and it spins because it has nowhere to go, right? So I always drill far enough, if that makes sense. And that doesn't mean your implant's going there, right? But it gives you the running room so that way your implant can keep going in and you don't bottom out, if that makes sense. So in a D1 type of bone scenario, I'll go over that in just a second. So just to kind of review, right? My 1.5 lance, my favorite, precision. The 2.0 lance can fit in the hole of the 1.5, also for sharp, but it's not rounded cutting edges. The 2.0 twist is the one with the cutting edges, okay? So you can move around the osteotomy a little bit more. And then there's 3 things that you're going to check. We can check the CT, right? We can read the CT. We can check the flutes while we're drilling, and we can also push the burr in and see if it just goes in, okay? And lots of x-rays along the way.
How hard are we?
Oh, just a little push. Yep, not too hard. Yeah, just like a little push. Like doing this weekend, I'll consistently come around and like kind of turn your hand or push with you guys, just to kind of like, I want everyone to feel exact pressures and stuff to do. Like how much pressure do we put when we're ratcheting it in, right? How much pressure do we put while we're placing the implant into the bone, right? With the handpiece. All those things you guys are gonna understand after this weekend. So for D1 bone, right? I would drill, right? You do a 3.5. You go 3.5 with your final depth. Then I take an X-ray. 3.75 in the kit is more of an optional. I like to say it's more optional because I usually skip over it and I'll go from a 3.5 to a 4.0. Now this weekend, go ahead and use every burr in that kit, right? Get used to every single size, every drilling more and more and more, and having more choices to move your osteotomy around, right? Because if you go from a 3.5 to a 4.0, your hole is a little bit bigger. So sometimes it's smarter to start off and go incrementally, right, down the list. But someday you're gonna not use that burr. Yeah, that's usually what happens. And then 4.0, and then a 4.3, right? So into the depth, right? So if you're placing a 10, you gotta go probably a 12 at that point, right? Because if 1.5 to 2, depending upon your soft tissue thickness, right? So you always wanna give yourself the running room. There's so many things to think about during the surgery that I want us to be able to plan the implant a proper size that allows us to drill a little bit deeper so we're not having to think about a few things, right? Like this. Because measuring all these variables can become slightly overwhelming when we're doing them for the first 5 times, right? So just make sure you don't get overwhelmed. Just make certain steps that can make your life easy as you're going through it. Now a D1 bone, I'd say you pretty much always have to use the 4.3 plus burr. So in this kit, there's a row of burrs that have a plus on them. And that's going to upsize the osteotomy by 0.3 millimeters. Is that correct? 0.3? Yeah. So, what's up? Under prep, yep. So if you use the regular taper drill, that's this one right here. This row of drills, and there's a mini kit and a regular kit. Everyone will get a little bit different, but I'll show you which row it is. But this is the row of burrs you're going to use. Now in a D1 bone scenario, if you're placing a 4.3, this is the 4.3 is the yellow, you're going to go to your plus burr. Your plus burr means that you're taking the burr is undersizing osteotomy for you. Now with this row, it's undersizing at 0.7. Okay. Now with a plus burr, it's undersizing it by 0.3. So it's just increasing the size of the osteotomy and letting you place it in D1 bone, right? I'd say D2, D3, once we understand what bone density, which case is actually what, you're only going to use the twist drills, okay, for the ones that undersize it by 0.7, right? So we have an implant that pulls you in and compresses bone, but we're also undersizing the osteotomy slightly. So like all those things just start adding up. Like, oh man, that could actually turn out a pretty stable implant, right? When you combine that thread design with the drilling protocol, and with you guys understanding whether it's D1 through D4, right? Like that's the secret. Any questions on this kit so far? Yeah. Yes. D1, D2. Yep. 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 Which one? A tab? So it does have a tab. I actually don't use the tab, but it does. They do have one. And which ones are you going to use that for? After, like, which one would you? A tap is a drill that's going to drill the first 2 to 3 millimeters of the osteotomy. What do you think that, what type of bone density would we want to drill that top part? Yeah, D1, D2, right? Probably. So that's perfectly adequate. The whole reason behind the tap drill is they say you take pressure off the cortex, right? There's something called pressure necrosis. Who believes in pressure necrosis? Who doesn't believe in pressure necrosis? Me. Okay, so pressure necrosis is just overstated, this insanely amount, and I hate it. I don't think sometimes clinicians, when we're teaching, I think sometimes we can be too safe. Like something I'm saying right now is not the same thing that I might say at a unit like Growth Summit. I'll be sub 10% dialed back, just 10%, right? But you have to tell people what actually happens, right, in these cases. Pressure necrosis means that you're placing an implant under so much strain on the top of the bone that the bone condenses to a point where you lose blood flow and the bone necroses or goes away. Now the question is, how much pressure do you need to cause for the implant to cause the bone loss, right? Now the studies say that is 180 Newton centimeters. That's insane, and there's multiple studies that show this. Now, what will happen before you reach 180 Newton centimeters? Your implant's gonna break. It's gonna freaking like fly. Like it's impossible. So all the reps have contests where they like try to like put the implant in and try to flower it. It's like almost impossible, right? I see that like some reps will like put it in, they like try to torque it in, and they can't get it to break. So the possibility of you reaching 100 Newton centimeters with your implant, 0. It's not possible because your driver would break or your implant would flower, right? Your implant would fracture down the sides, or your implant driver would snap off on the implant. So pressure necrosis is not a thing. But what they really mean when they say pressure necrosis, they really mean that there's not enough biology above the implant. So they get those two concepts confused. So it's actually biological width that they're trying to talk about. They just don't know what to say like properly, right? So if you place an implant, even with the cortex, what's going to happen? Let's say the tissue thickness is 2 millimeters, and you place the implant even with the crest of the bone. How much biology do we have above the implant? 2 millimeters. How much do we need? 3 or 4. Guess what's going to happen? Bone loss. That bone loss is not pressure necrosis. That bone loss is because of the biological width, right? Those concepts get confused like crazy. You notice that too? Yeah, as I just know that concept just needs to be really, really just like hammered home for people now, because that concept is just not true. It's not a thing. And we used to believe it. Everyone used to believe this, right? Like 80s, 90s, like those things. But these articles now are like 20, 30 years old that have proven this now. So I don't want you guys to be worried about pressure necrosis so much, okay? But we're actually going to take it a step further to ensure that you guys don't have pressure necrosis. And the reason and how we're going to do that is while you're placing an implant in, the goal is to get exactly 45 Newton centimeters on your implant, between 35 and 45, okay? So let's say you're putting an implant in, and it's a little bit tighter than 45. And everyone this weekend is going to be able to feel that because it's such a good implant. It's gonna reach a point where you're just kind of putting your implant in, and then it's gonna get to the point where you have to like almost put your bicep in it. You're like, ooh. At that point, stop. Don't do that. And you guys will all feel that this weekend, I promise. Because if you keep going with it, you could break your implant, right? Will you? No. I've never actually, that's not true. I flowered one Neodent implant, and it was like 2 weeks ago. It was really bizarre. But I've never done that, only that one time. Has only happened to me. But you're more likely to break the driver off. So if you have an implant that's very stable, the implant driver will go into the implant and cause a cold weld, right? So the key is don't cause that cold weld. The cold weld can be caused by going too much on the torque wrench. So there'll be a difference that you see, which is putting an implant in versus having to like turn it and put your bicep into it, okay? That'd probably be at least over 80 to 100 at that point, is if you kept doing it at that motion. But the goal is 35 to 45, okay? That's the goal, so we don't have something happen. Now, if we still believe that pressure necrosis is a thing, even after this entire weekend, that's okay. I want everyone to, once the implant is down, untorque it, like 2 half turns or like 1 full turn, and then grab your torque wrench and put the implant exactly on 45 Newton centimeters. So that way you can sleep at night, right? In the beginning, you're going to think of all these different variables of like, oh, maybe pressure necrosis is a thing, right? You have all these crazy thoughts that run through your brain after you do your first surgery. So you're like, oh, is the patient going to be okay, right? Is the incision going to heal? They're going to have swelling. Did I do the right meds, right? But you could also take this kind of category out of your brain altogether by getting some style points at the end by just on half torquing it and then torquing it to exactly 45 with the torque wrench. Because the torque wrench has a little lever that will read exactly how much it will be. Does that make sense to you? It's kind of like style points at the end. Like, go for exactly 35, 45. That makes you feel better. You know, just eliminate one of those variables. That way you're not worried about that one, right? So as we're doing surgery, we're eliminating variables and concerns as we're developing our skills.
Can you only do that if you're over 45? Like
Yes. Yep. And it would probably be closer to 80 to 100 Newton centimeters at that point in time, if something was to break. Yep. Okay. So ours is classified in here. Now, when you're putting an implant in, you want the proper speed to put the implant in, okay? So the implant is meant to go down into the hole at a specific speed. And that hole, the Neodent implant, is meant to go in at 30 RPMs, okay? So you want it to go with the proper like speed. Now, if you have, let's say you have an implant that's more knife edged, right? And you are putting the implant in, the chances of that implant stopping, like as you're going in, decreases because it's so knife edged. It just keeps going in, right? But reason why I like the Neodent one, same thing, is it starts to go in, and then the Newton centimeters will stop the implant because it actually reads the stability better. Now, at any point in time, if you want to know exactly how stable something is, sometimes the Neodent, you might be going 30 RPMs through Newton centimeters, and if you stop it and try to start it again, it won't go because it's already condensing the bone at that point. It's really interesting. But some of the more knife-edged implants will just keep going, and it might never stop, right? So now if you're placing an implant at 30 Newton centimeters, 30 RPMs is going to drilling. The speed is 30 RPMs. Now the Newton centimeters is going to be at 35 Newton centimeters. So the implant will stop once it reaches that, okay? If it stops and there is 4 millimeters of implant threads above the bone, take the implant out, okay? Take it out, increase your burr size, or most likely by 1 diameter, and check your depth, okay? This is so key. If it doesn't go down, why doesn't it go down? It didn't go down because either we didn't drill deep enough or wide enough, right? Because we were drilling to something that we thought was D2, but maybe it's D1, right? And that's okay. So it's all a learning experience. So you take the implant out, drill 1 burr wider, check your depth, and then put the implant back in, the same one. And then you'll notice that it goes down. Now, if it stops 1 to 2 millimeters above the bone, that's fantastic. I think that's usually the goal, is around 1 millimeter above the bone. Because if you're at 35 Newton centimeters, you still have to torque the implant in. Now, the deeper you go with the implant, the more stable the implant is going to be, right? So by the time you get to the bottom of your osteotomy, you're at 45, right? Perfect. That's what we're going for. But that's why I want everyone to set their motors to 35, because it'll give you a really good running room on when to take the implant out versus keep going with it, right? Now, if you're placing the implant and the implant's not stopping, right? You're even with the bone, I would stop, because we most likely over drilled, right? Which is okay. At that point, take a torque wrench to it, and then we're going to just kind of feel how stable it is as we're going down. Now, if it's like 25 or less, I would just take it out and put an implant in that's bigger, just by one size width. And then that implant will miraculously go to 35. It's fantastic. But I just want everyone to focus on that. Like, focus on the proper speed to put an implant in, and that will give away exactly what to do with that implant. Yes. So let's say it's a 4.3, go to a 5. Yep. But that's why also during our planning, if it's a premolar, we don't want to plan for like the biggest implant, like a 4.3, plan a 4.0, right? So that way you could upsize to the 4.3, right? So you have always something to upsize to. And if you're at a 5, let's say you're at a molar that needs a 5, your upsize could be the depth, right? Or your upsize could be the width. Or your upsize could be going from helix to a drive. So you have like 3 options to upsize. But that's why I don't use the drive in the beginning, is you eliminate your options to upsize something, if that makes sense. Yep. So like in full arch stuff, I consistently place a 4.3 on my distal ones, the big ones, like a 4.3/13. And now some docs place 16s and 18s. But what if you have to upsize? Now you use the biggest implant already, now you're screwed. So I always plan on upsizing during it, so that way I'm always getting to 35 or 45. That makes sense. Because inevitably, we're human. We're all going to have surgical errors. But our plan can decrease the chance that our surgical errors will lead to something where we can't place the implant. Hence, no spinners, right? No spinners on implants anymore. Let's see. Questions so far on stuff? Yeah.
Last question.
Yes.
So I had this earlier this year, an osteotomy that had like 0 bleeding.
Yeah.
Do you have any techniques to induce bleeding?
To induce bleeding?
Yeah.
And like a D1 bone case scenario? It failed? We'll probably just burn the bone then. And drill slow, right? So that's when you just have to drill slower, to be really honest with you. Just being gentle, just literally just be gentle and drop the speed down. And for that one, I would probably drill slower, maybe like 200 to 300 RPMs. And right, and increments, right? Very incremental, don't press like too much. So just be careful. And burning bone is a real thing. Burning bone is a way bigger issue than like a pressure necrosis thing ever has been. That could be that too. There are just some cases where the bone is just so freaking crazy that like it's just so insanely like concrete, right? And those you're gonna want to over prep. There's some where I would drill to a 5 and then place a 4.3. That's how stable some of those that bone can actually be. Again, that's on the outside, the outliers, right? Right, like a bell curve. Everything else is in the middle. There's going to be a 5% one other way, with the D5 bone, right, or like a D0 bone with very little vasculature. But in the D1 bone cases, you're still going to want to place your implant deeper. Give it space, right, to heal, because you will get more bone loss because the bone is so thick, and without little bone, you will get a millimeter of bone loss just because you entered the site. So, right, does that make sense to you? So if you don't have bone supply, if you open a flap and you just close the flap, let's say you just make an incision, open it, full thickness, and then close it, you'll get bone loss because the body is trying to re-attack it and create stability. So on those ones, that's why you want to, I would say, place closer to 2 below, because you'll most likely expect to have to 1 millimeter bone loss. because of the lack of blood supply. But precision. So I want everyone to use these burrs. This is a narrow implant that I did with just my hands. But how would I be able to get that 2.0 in if I didn't put the 1.5 in first? Not a freaking chance, right? Not a chance. There's no way. And then this is the implants. They ended up really nice. But there's no way I would have been able to do that if I didn't like properly follow my own protocols, right? If I violated my own rules, starting off smaller and work your way up. All right. Now the kits, we have, this is the prosthetic kit. There'll also be a surgical kit in the room, and there'll be a prosthetic kit in the room. And there's a few drivers here. This is the torque wrench. This is the lever I was talking about. And then at the bottom of the lever, this is 45 right here, and this is 60 right there. So it goes up to 60 where we'll read it. Our goal is between 35 and 45. That's going to be our goal. And there's also some stoppers, which are really cool. I think also eliminating variables that will be hard in the beginning of surgery, taking your mind off of things, right? So if you use a stopper, guess what you don't have to be worried about? The depth. Fantastic, right? That's great. So eliminating variables that you have to worry about in the beginning is just the best thing ever. I used to have these little Blue Sky Bio burrs, and they had a stopper on them for 8, 10, 11.5, and 13. They're collecting dust in my office now, but I used that for like 5 years. I loved it because you just sink the burr down. And I'm like, oh, we don't have to worry about anything, right? Because your burr is going to drop down to the rate, and I'm not having to concentrate on like reading the lines as I'm going. But it's easier to read the lines if you drill slower, right? That's the thing, because if you drill too high speed, by the time you actually get to 10, what if you're at 8? You just didn't see it, right? You just drilled too shallow. So drilling slower will improve your posture, right? So you're not just bent down looking exactly where you are, but it will also increase your efficiency, and then eliminate the things you're worried about during the surgery. So just add tools, creative ideas to make sure your surgery goes better. Oh, good question. So what I would do is I would just let your rep know that you want these burrs. There's a burrs with the stoppers on them.
So it's a completely different burr as the stoppers.
Yeah, exactly. So this is, all right, so if everyone buys a Newton kit, ask for the burrs that are the stopper ones, not the other ones. Then that way you already have it, the stoppers there, and you only have to get the separate smaller kit where it has the actual just stoppers on it, if that makes sense. Because this little stopper goes onto that drill. But if you have a kit that already has those drills in it, right, you're already halfway there. So it's kind of nice. Just ask for maybe that kit with those burrs, the stopper burrs, and then ask for the stopper portion on the side, if that makes sense. That's what I try to get people to do. They're kind of thinking, right? They're a little bit smarter. But you're asking for the right drills. If you want to use them, you can. If you don't want to use them, you don't have to either. And let's go over a quick graph of like what the burrs look like, right? So you can see the actual sequence of the burr itself and just the reading label. Now, you have 1.5, right? That's our precision burr. A pilot 2.0, that can go in that same hole. A 2.0 twist is the one that has the side cutting, right? So sometimes if you go from a 1.5 to a 2.0 twist, it kind of bounces around at the top of it, of the osteotomy, because the bone is hard. And then your burr just can't go right in the center, if that makes sense. So upsizing increments like that just ensures just like a smooth process. There is such thing as a Lindemann burr. Anyone ever heard of a Lindemann burr? Yeah, Lindemann burrs can be great. Now, one of the reasons I don't like them as much is this burr itself is 2.3. So if you start off by moving osteotomy around with a 2.3, now how big is your hole, right? You're having too big of holes. That's why I like to start more of a precision mindset, right? 1.5, 2.0, 2.0, and then a 3.5. But if you start off with a 2.3 and now you have to do a bunch of angle corrections, you're already at a 3.5, right? It's a pretty big size hole at that point. So it is a good burr, but just use it smart and be conscious of the size of the burr, right? I think everyone loves different tools. It's very sharp as well. Liniment burrs are, but I'd say just be careful with that, with the width of it. This one is, yep. Liniments, yeah, you can get one honestly from anywhere. I think Dental Re is one that DSN has like a discount code for. I think they're like $10 there for a liniment burr. Now these are the more the twist burrs, not the plus size, right? So we're going to start off with that twist burr one, just that one row. Here we go. There's a 3.5, 3.75, 4.0, 4.3, and 5.0. Okay. Now the measurements on this, the first line is an 8. Okay. The silver is where your brain's going to really just go, like when you're watching it. And the bottom of the silver is 11.5. Okay. The top of the silver is a 13. Most implants, if you place in like a 10, you're always drilling to 11.5, right? So just really just keep your eye on that silver mark, whether it's the bottom of the silver or like over the top of the silver, if that makes sense. If you're placing an 8, you're going to go to a 10, right? If the vital anatomy is there, right? So obviously not going to intentionally perforate and go into the sinus by 5 millimeters, right? Like that would, we're not doing that. But same thing, we want to go to the depth. Questions on the burrs yet? On anything about the kit? Not yet. And when we're placing the implant in, we have the attachment for the handpiece itself. The motor is going to be 30 newton centimeters at 35 RPMs, not 30, sorry. And then we have 2 different hand drivers for the torque wrench. So the goal is to first put the implant in, and you're going to see how far above the bone it stops, right? That's going to give us a really nice running room in terms of, do we need to take it out or can I ratchet it in, right? So if the implant is even with the bone, 1 to 2 millimeters of threads exposed, then we're going to just go right to our ratchet and finish taking the implant down, right? Now if the implant gets even with the bone, while putting your implant in here, we're going to take that implant out. We're going to put a bigger one in. Now if the implant, when we're putting it in, stops this far above, just take it out, right? Take it out instantly, don't even think about it. And then we're going to drill 1 size wider and check our depth, right? And then we're gonna put the implant right back in, okay? Now there's 2 different sizes. There's a short one and there's a long one. I'd say 80% of the time, 90% of the time, I'm using the longer one, right? Because there's usually a tooth next to the implant, right? There are little other things too, tricks that you can use, like this. It's a burr that is just a 2.0 that allows you to drill and get the proper width for the tooth next to it. Like how far away from the adjacent tooth do you go, right, while you're drilling? So this is kind of, it's sometimes nice to use. You don't have to go down the osteotomy with it. You're just doing the top of it, right? Like just the first 2 millimeters. So you're doing more precision by drilling a tiny little hole that's 2 millimeters deep at the top of the ridge so you can sneak your 1.5 into, right? Just gives you a nice little running room on what the size of the tooth is that you're trying to plan, and where that needs to go to make sure you have the correct restorative space, right? Now, if you're placing an implant between 2 teeth, right? How many millimeters of bone do we want between the 2 teeth on each side of the implant? Like 1.5, right? 1.5 to 2 is really good. Now that would mean if you're placing 2 implants next to each other, you need 3 millimeters between them. Okay. I always, when I place 2 implants, I always place the one and then I place the second. The reason is, or if you're doing a bridge, let's say you're placing, there's three holes, right? And you're going to place a bridge, or you can place 3 implants, right? You want to place the first implant, then the second one on the opposite side of the bridge, and then if you have room, you do the one in the middle, is what you do. So don't drill the 2 holes at the same time, okay? Because if you do, you could block yourself out, or you could end up too close. That's really bad, right? So place the one, make sure that's the correct dimension away from the tooth. So you place the one that's closest to the tooth, right? If it's like a distal extension, like a 20, if you have 29, you're placing 30 and 31. Place 30, then place 31 right after that. Does that make sense to you? Like why I would place like one at a time? I was like, yep. Yep. And if you're placing 2 implants, the minimum, like it's important to measure the distances of that ridge, right? What if the patient actually needs ortho, right? Or needs a tooth uprighted? Like how do you squeeze 2 implants in if you don't have enough room? You need minimally 8 millimeters of space between 2 teeth to achieve 2 implants, right? Because if the average implant is 4 millimeters and you're going to be 1.5 millimeter away, you're already at 7, right? So just 8 millimeters between 2 teeth should be your minimum. Just don't squeeze things in too early on. I think I used to squeeze implants in. I'm like, oh, I got this, right? Then you squeeze the implant in this ridge, and then you get some bone loss, and now the site is like unrecoverable, right? Because you ended up with bone loss, when really we should have augmented that ridge first, right? So just cherry pick these cases, and remember, 95% of cases are going to be just perfect enough for you guys to place. Just don't pick the cases that it's less than 8 millimeters between 2 teeth, and don't pick the cases where it's less than 6 millimeters of bone width, right? From buccal to lingual. Because around 5.5 to 6, if you're placing an implant that's even 3.5 plus 1.5 plus 1.5, right? We're already at 6. Man, that's squeezing it in right there. So just don't squeeze things in too early. Questions on that? On this stuff yet? No? Cool. Yeah. Hey, Kate, how much more time do we have? Do you know?
It's on your paper.
Yeah. This says, because I think we're going to do the implant right now, right? Let's see if the patient's ready up there. Sorry, 10, 15, you know what I mean?
Okay, I'll go check.
Let's see if they're ready. Thank you. All right. Questions so far? Anyone have questions for me on the single implant docs yet? No? Did you learn a lot? That was a lot, right? There's a lot of information to think about. Just don't get overwhelmed on me, okay? I would be doing you a disservice if I didn't walk you through all these different variables. I want to more give you a lot of information today, and then we're all going to sort this out throughout the next few days, okay? So it's going to be a really, really, really fun weekend. I think the case that we do first is more of like an overdenture case. I just want us to have the experience of just drilling a hole for the first one, okay? That's how I like to do it in the beginning. I want you guys to see a flap, right? And I want you to see different types of bone on one arch. I think that's a really cool thing to see visually first, so I always like to do that first. And then most of the rest of the cases for the weekend will be single implants, like onesie twosies. Yep. Because I want you guys to see the flap too, right? Like, I want you guys to see a big flap and you're like, oh, this is fine, right? There's so many mysteries that go on our brain, like how big can I make a flap? Like, can I look at the mental nerve, right? Little things like that I want you guys to see, like periosteal releases. We'll do some periosteal releases and you'll see some more complicated suturing that I'll do. So all these things will stack and you guys are leave here just super stoked. I hope you guys call some patients like tomorrow, like get them in for like next week, right? So that's what I used to do. I'll go to a course, but I would intentionally plan that next week to have the implants. That would just force me to do it, right? That's the only way you're going to get good is implementing.